I have absolutely no experience, but I thought, something new need to be presented because in vitro fertilization has redefined the human species' ability to reproduce since its clinical introduction in 1978. So not only it was initially designed for infertility, and now you can find it that this is expanded its horizon to include medical and genetic conditions as well as for fertility preservations. So the newer and newer ideas keep going on. And today I'm going to present progestin primed ovarian stimulation is a new dawn in the ovarian stimulation protocol in IVF. I will talk about the need for pituitary suppression in ART cycles, the conventional protocols which we are using, the long and short protocol, why progesterone for pituitary suppression, clinical studies, and her future role. This particular slide, I take you back to the hormonal interface in ovulation. Growing follicle houses and produces estradiol, and increasing estradiol suggests impending ovulation. As high the estrogen, the better the follicle development is. Rising estradiol signals an overdrive of LH, which surges to peak in 24 to 48 hours before ovulation. This LH surge is responsible for coaxing the egg out of the follicle to go through fallopian tube for due course for fertilization and so on. So just to make it more simpler, you will find there are from hypothalamus pituitary ovarian axis, GnRH is a pulsatile hormone from hypothalamus. It acts on the pituitary to produce FSH and LH. Luteinizing hormone stimulates the theca cells to produce androgens, which is then converted to estrogen. Upon achieving a critical level of estradiol, it begins to have a positive feedback on LH release, which results in LH surge, and that initiates ovulation. Now, what if the LH surge is asynchronous and premature? It is a big stumble during controlled ovarian stimulation cycle. The impact of premature luteinization is that it impacts the quality of ovum as it does not obtain a proper development. And eventually the whole cycle yields a compromised egg, adding to the chances of empty follicle syndrome or cycle cancellation. The rise in egg or embryo incompetence can be seen with increased risk of chromosomal aneuploidy. Now, this premature LH surge is seen as a good 20 to 25% of IVF cycles during controlled ovary stimulation in women undergoing IVF. And thus, premature LH surge should primarily be prevented. And then now we see that we are conventionally using two protocols, a long protocol and short protocol. And gradually we are switching over to NTAG protocol now, because I think in our center, almost 96% of the IVF cycles are using NTAG protocol. And both achieve the control of LH surge. We don't have to tell to this August gathering that the long protocol is definitely complex. It definitely has a little more chances of OHSs, while NTAG protocol is patient friendly, and still you can find a proportion of patients may be experiencing premature LH surge, especially old patients and patients with decreased ovarian reserve. Now you can see this is the mechanism brought about by in long protocol. You can find that the pituitary downregulation takes place, while in NTAG protocol there's a direct gonadotrophin suppression. Now the quest for improvement is on to improve the efficacy for better safety profile, and it should be patient friendly. Over the past few years, the research has focused on the replacement of gonadotrophin analogs by progestins by controlling the premature LH surge. In a normal ovulatory cycle, the corpus luteum secretes progesterone. Progesterone strongly inhibits pulsatile GnRH and LH secretion and prevents E2-induced positive feedback mechanism, and this prevents premature LH surge. premature utilization. You can see this is the schematic representation. Once you find that if exogenous progesterone is used, it can be used to control LH surge. Consistent LH suppression during the luteal phase with no spontaneous LH surge. But an LH surge can be triggered by GnRH agonist. I repeat again, exogenous progesterone can be used to control LH surge. The consistent LH suppression during luteal phase with no spontaneous LH surge. But this LH surge can be triggered by giving GnRH agonist as a trigger. And this makes progesterone a viable option to suppress these pituitary gland secretion during the luteal phase. In earlier days, when our focus had been mainly on a fresh ET, the progesterone administration definitely impacted endometrial receptivity, so it never found its place. But now we see most of the cycles we are using a frozen ET, and so this issue of using progesterone has been resolved. It helps in achieving this frozen cycle, helps in achieving superior quality embryo, and precise thawing technique can help for a better ET outcomes. So the progesterone is safe alternative to GnRH analog, suppressing premature LH under control over hyperstimulation in IVF cycles. It is safe and it is efficacious. The disadvantage of conventional short protocol is relatively high cost and daily subcutaneous injections, which patient does not like that, after some time their daily 2 injections are being given. So now you see the progesterone primed ovarian stimulation there is a new dawn where one can use an oral administration of exogenous progesterone beginning in the early follicular phase is used in IVF treatment. Now, this is $1 million slide, which I've taken it from Dr. K.D. Nayyar's presentation, that it shows that conventional NTAC protocol. We have a gonadotropin being used from the day 1 of stimulation, and later on adding on NTAC with a fixed protocol or flexible protocol. And you are all familiar with this particular protocol. Now, what has happened in progesterone primed estrogen stimulation cycle is that you start gonadotropins. On the same day of stimulation, you start progesterone. You can use meprate, you can use dydrogesterone, and it is a friendly in that particular way that it can be taken orally. Now, these are the various progesterones which are there in the market, and the transformation daily doses has been written that if you're using a progesterone, then it is 200 to 300. If you're using a dydrogesterone, 10 to 20 milligram, and if you're using medroxyprogesterone acetate, 5 to 10 milligram tablet has been done. Now, for the dose which suppresses ovulation is that for dydrogesterone it is set over 30, and for medroxyprogesterone it is said to be 10. So let's recap what I have said still so far. That progesterone primed ovarian stimulation, it blocks the luteinizing hormone surge through progesterone instead of traditional downregulation by gonadotropin antags, both agonist and antag. The progesterone primed estrogen stimulation can effectively serve as an alternative to conventional treatment with GnRH analog. First to propose this was Kuang et al. He used exogenous progesterone in the form of medroxyprogesterone acetate and dydrogesterone also. And he started in the early follicular phase along with the gonadotropin in the controlled ovarian stimulation protocols of IVF. Progesterone primed ovarian stimulation can effectively prevent the activation and the transmission phases of estradiol, induce LH surges, and thus serves as an alternative to conventional treatment with GnRH analog. It was a prospective randomized controlled trial where medroxyprogesterone acetate was used to prevent LH surge in the controlled ovarian stimulation cycle. And this was, as I said, it is a segmented cycle where the frozen ET was planned for the next cycle. HMG and medroxyprogesterone were administered simultaneously, beginning on cycle day 3. The ovulation was induced with GnRH agonist, or the trigger, either the trigger was agonist or it was co-triggered with GnRH and HCG when a dominant follicle matured. A short protocol was used in control groups. Viable embryos were cryopreserved for later transfer in both protocols. The results were that the number of oocytes which were retrieved in the study group was similar to those in control, which is conventional ANTAC protocol. It showed that medroxyprogesterone acetate is effective as an oral treatment, the prevention of premature LH surge in a woman undergoing IVF cycle. The pregnancy outcome from FET indicated that the embryo originating from this regime had similar development potential as those from the control groups of conventional ANTAC cycle. On the review of literature, we found there was another study, 2021, where Dardag has used dydrogesterone to suppress premature luteinizing hormone on the cycle outcome in controlled ovarian hyperstimulation as for the IVF is concerned. And you can see here that gonadotroph, this dydrogesterone was added whenever the follicle size was 12 millimeter or E2 was more than 300 picogram. And the dose used was 20 milligram twice a day. They have very specifically mentioned about the drug which had been used was the dufoston, 10 milligram. The dose was 20 milligram twice a day was started when the dominant follicle reached 12 millimeter size or the estradiol level were more than 300 picogram. 105 ladies were participated in this study. 52 were induced with dydrogesterone, while 53 had a conventional GnRH ANTAC protocol. And it showed that premature ovulation was observed in 11.5% and 0% in dydrogesterone and GnRH ANTAC groups, respectively. The dydrogesterone was used as an alternative to ANTAC regime in patients where the embryo transfer is not planned in the same way. Now, in another study using dydrogesterone, primed ovarian stimulation is an effective alternative to gonadotropin-releasing hormone ANTAC protocol for freeze-all cycles in polycystic ovarian disease. Here again, they took 525 cases, and the progesterone used was dydrogesterone in the dose of 20 milligram right on the day of HMG was started, and the other control was ANTAC conventional protocol. There was no significant difference in clinical pregnancy rate of fresh frozen embryo transfer cycles between dydrogesterone and the conventional ANTAC group. The pregnancy rate was 56% versus 55.6% respectively. There was no significant difference in biochemical pregnancy, implantation rate, miscarriage rate in both the groups. So the conclusion was dydrogesterone primed ovarian stimulation seems to be an effective alternative to the GnRH ANTAC protocol for freeze-all cycles in PCOS patients. Now, another study by Huang, where they had studied, this came in 2019, they studied the neonatal outcomes and congenital malformations in children born after dydrogesterone application and progesterone primed ovarian stimulation protocol for IVF. This was a retrospective study. And the sample size was 3,556 live-born IVF cycles, and they found that the newborn information was gathered from the standardized follow-up questionnaires and from the access of the records within 7 days after birth. They found that for adverse neonatal outcome, the two protocols showed no significant difference on the rates of the low birth weight, very low birth weight, preterm birth, very preterm birth, small for gestational age, large for gestational age, and early neonatal deaths after adjustment. The incidence of major malformations in dydrogesterone plus HMG protocol was similar to conventional ANTAC protocol, showing thereby that dydrogesterone in PCOS protocol was safe option for the newborn population without compromising neonatal outcome or increasing congenital malformation risk. Another study by Iwami and again, this was in 2018, new trial of progestin primed ovarian stimulation using dydrogesterone versus typical conventional NTAG protocol. And again, these people found the dose used by dydrogesterone was 20 milligram a day in the study group, and this was compared with the conventional NTAG protocol, and they found that the pregnancy rate was 40% versus 38%. The clinical pregnancy rate in the study was 52.8, was also not inferior to the control group, which was 49.5%, almost the same. The clinical and ongoing pregnancy rates in dydrogesterone group was comparable to those in control group. Now, this has been an RCT, came in human reproduction in 2018, and they studied 506 cycles of IVF. And it was a prospective study using 516 patients into two treatment groups. One was HMG plus dydrogesterone, another was HMG plus medroxyprogesterone acetate. And again, they found that dydrogesterone, which exhibits no or a weak inhibition of ovulation at normal dosage, can serve as an HMG adjuvant during ovarian cycles. There was no difference whether you use medroxyprogesterone acetate or dydrogesterone. This was another randomized controlled trial, again comparing dydrogesterone with the conventional GnRH NTAG protocol. In this RCT, 200 women were undergoing IVF cycles, were randomly assigned to two groups. HMG, one group had 20 milligram of dydrogesterone along with HMG. The second group received conventional NTAG protocol. And they found that the efficacy and the easy use of dydrogesterone was reasonable to use it, and it is a good alternative to GnRH NTAG for the prevention of premature LH surge. There was no difference in the two groups. Now, this is our Dr. K.D. Nair, who made a poster presentation in Ashram in 2022 and bagged the prize. And he used medroxyprogesterone acetate. Along with HMG, he is using 10 milligram of medroxyprogesterone acetate, usually by the famous brand name of Maprate. And again, he found that the clinical pregnancy rate, people where he used in progesterone primed was almost 39% as compared to NTAG protocol, where it was 40%. And the rest things were absolutely same. He will make his comment because he has written down in one case there had been a mild OHSS, while in conventional, the mild OHSS was not seen in progesterone primed estrogen stimulation, while one case of NTAG protocol showed that kind of features. So he concluded that progesterone primed ovarian stimulation can achieve similar embryological and a clinical outcome while reducing the incidence of ovarian hyperstimulation syndrome as compared to the fixed NTAG protocol. Hence, progesterone primed ovarian stimulation with MPA seems to be patient-friendly, very cost-effective choice for a woman undergoing ovarian stimulation in IVF cycles. Now, question comes, are there any difference in euploidy rates when you are using an oral dydrogesterone primed ovarian stimulation protocol or conventional NTAG protocol? Now, this here they had studied 780 cycles. NGS testing was also done. No ovarian response was seen, and the final outcome was that no significant difference between dydrogesterone and GnRH NTAG protocol was noticed. So they found that dydrogesterone is a safe and efficacious treatment modality to prevent LH surge in freeze-all cycles. Safety of progesterone, we all know that we have been using it for a long time, so one need not doubt, and I have presented the studies in favor of that. And coming to the finally to the SWOT analysis of progesterone primed estrogen stimulation, the strength is it is low cost, same pregnancy rate, and the quality and the number of oocytes are also the same in two protocols, and no OHSS. The weaknesses are that, you know, there are few studies, RCTs are only available. A lot of work has to be done everywhere. The opportunities are that more euploid blastocysts in poor responders in one cycle. You can use a double stimulation also. Dr. KD and Dr. Brigadier Sharma will comment on that. it is a patient-friendly protocol all the same. As for the threats are concerned, we have to bring about change in our current practice, and need for a good cryopreservation unit you need to have, and this can only be used whenever you're using a segmented IVF cycles. And we have a limited data as far as obstetrical and perinatal outcomes are concerned. Now, these are the future roles of this particular protocol to prevent premature LH surge. It can be used in donor stimulation. I was talking to Dr. K.D. Nair. He says that now it is his practice to use progesterone in donor cycles. It can be used also in cases of fertility preservation, in PGD, wherever you want to do an ovarian stimulation, a double ovarian stimulation, where the patient is of decreased ovarian reserve, IVF in women at risk of ovarian hyperstimulation syndrome. This particular protocol can be used, and these are the future application of the same. So the future role of this particular protocol is the further studies are badly needed by all of us to produce reproducibility, and we know it for sure that it works, and the obstetrical, prenatal, and long-term neonatal outcomes before this protocol can be introduced on a wider scale. So thank you very much.